I would like to welcome our first speaker of the day, Dr. Henry Luzze. Dr. Luzze is the Assistant Commissioner of Health Services, Ministry of Health in Uganda. And today he's going to be talking about improving TB screenings in Uganda and their experience with Delft Light, mobile clinics, and CAD4TB. Dr. Luzze, please take away.
Thank you very much. Please just make sure that I'm audible that side.
Yes, Dr. Luzze, you are. Yeah, we can hear you.
Oh, all right. Thank you for the opportunity and for inviting me to make this presentation on improving tuberculosis screening in Uganda and sharing the experience with the Delft Light, mobile clinics, and CAD4TB from deployment to long-term impact. And as you mentioned, I'm the Assistant Commissioner, the Program Manager for the National TB and Leprosy Program in the Ministry of Health, Uganda. Next slide, please. Yeah, as a way of landscape, I'll start with some of the challenges we experience as a country, that we have an estimated annual TB incidence of around 96,000 cases per year. With the notification gap, we estimate that around 10,000 cases are undiagnosed or unreported every year. We have high burden areas in the northern parts of the country. We have islands in Lake Victoria. We also have urban hotspots in the city and some slum areas. Traditional symptom-based screening, as we know, has limitations of low sensitivity, especially in asymptomatic populations. Next. This graph is showing us the estimated TB incidence rate in Uganda, and it is derived from the WHO Global Report of 2025. You can see that trend from 2010 to 2024. And in 2024, our incidence was slightly below 200 cases per 100,000. But also it's important to note that in that same year, we were able to detect only 88,000 TB patients with a treatment coverage of 90%, meaning that we still have gaps in our treatment coverage. Next. So following those gaps, we had a strategic response, including some innovative screening approaches. In 2020, we had a very big case detection gap of around 40%. So we needed to shift our active case finding using the Delft Light digital X-ray backup at the facility and also in communities. Then we also introduced the mobile one-stop TB clinics, which are the trucks or the vans, and they introduced the CAD4TB artificial intelligence software for the real-time triage with a threshold of 50 and above. And for every person who scored 50 and above, we would collect a sample that we would send to molecular diagnostic techniques, especially the gene expert, which is more accessible than any other. But also we looked at the issue of integrating these screening approaches to ensure that we provide same-day confirmation of testing and initiating treatment on the same day. Also, by doing this, we worked with a number of partners, including of the Delft Image, the US government, Global Fund, among others. The picture on the right hand is the one where we are launching the Delft Light systems by the US ambassador and other partners in the Ministry of Health. Next. Well, this slide is intended to show how the country has been steadily progressing in the deployment of these systems from 2020 to 2026. Because of the experience we have been getting along the way, we have been able to convince a number of our partners to make sure to procure more of these gadgets And the partners that have supported us, as you can see on the extreme right column, is the Global Fund, the Stop TB partnership. We had also the Uganda Catholic Medical Bureau working with the government, with the German Association. We also had the US government coming in as part of the supporters of this deployment of these systems. Next, please. Now, this shows us the timeline showing growth from 2020 to 2025. You can see the years on the extreme left when the system started. You can see the numbers we have been screening in the total screened column, and the abnormal X-rays, and the percentages, and the contribution to the TB yield. What is here to see is that we have been progressively increasing the numbers of people we screen. From 2021, you can see we had only over 5,000, but in 2025 we had 137,000. This means that we increased the awareness, but more important, we increased the numbers of the Delft light systems in the country, so that now we are able to reach more population. And if you see the totals below, you can see that over that time, using the Delft light systems and the CAD4TB, we have been able to reach over 250,000 people, and we were able to get nearly 58,000 with abnormal X-rays. That is, if now we put our threshold to 30 and above, which is contributing to 22% as far as people with abnormal X-rays are concerned. And we're able to send a number of them for the molecular testing, and we confirmed 4,500 persons with TB, which is a yield of 8%. But in addition, we are also able to clinically diagnose 3,500 patients with clinical tuberculosis using initially these systems, which contributed to 8,000 TB patients and that were diagnosed and started on treatment. The importance of this overall is that these are community activities. It's meaning that most likely would have not reached these 8,000 people in communities if it wasn't for these systems. And they would be there still spreading to the communities. But because of this, we can go to the communities and we are able to screen people in communities who could not easily come to the facilities. Next. Yes, I just want again to demonstrate one other experience we have had as far as screening for people living with HIV using these systems and the CAD4TB. This was done beginning this year, from January to February and March, with screening within the TB clinic. So you can see at the bottom that 11% TB.
Dr. Luzze, yeah, there's a little bit of a lag. Can you repeat what you just said? I'm sorry.
Oh, with this slide or even before?
Yeah, just this slide.
Okay. What I'm saying is that one of the approaches we have started using this year is focusing on some areas where we can get optimal yield. And here I'm demonstrating from January to March, our screening for people living with HIV using the light system and the CAD4TB. At the bottom of it, you can see the summary that 11% yield from screening in chronic care clinics using the light systems and the CAD4TB. So it actually gives us a higher yield than going into the general population as we had already seen. Next. Yeah, now these are the key achievements that we've had ever since we've got the systems in 2021, that we have been able to reach over 250 people that have been screened, and we've been able to take 22% abnormal readings and yielding 4,500 TB patients that have been confirmed with tuberculosis, which is significantly higher in people living with HIV TB contacts and the hard-to-reach communities. And on the right, you can see the pictorial of the van that we acquired from Delft with X-ray machines in there and the software CAD4TB into the communities, getting the people screened. These people are remote, they are in remote communities, they would not have been able to reach facilities easily. So this is one of the demonstrations that we can show. Next, please. Yes, so now this is another achievement of integrating the digital X-ray and the computer-aided diagnosis screening during the CAST. CAST is our community awareness screening and testing. And as a country, we do this every quarter, biannually. So every 6 months, we do the screening where we go to the communities and mobilize and create awareness and do the screening. And we are relying so much on the systems that we have. And you can see that the mobile X-ray and the CAD4TB patients of the 1,243 that were identified, which is 34% using the Delft systems and the CAD4TB. It also offers a faster diagnosis, which offers real-time CAD, which is reducing the turnaround time. And also we have the expanded access to people who don't usually come to facilities using our mobile clinic remote outreaches. This is data for only March, where we conducted this just 1 month ago, where we had this information from the different regions of the country. But overall, that's what we are able to get. Next slide. Yeah, along the way, we've learned some lessons that we would want to share. That these portable systems with artificial intelligence combination works best in both community and also facility settings. We've noted the higher yield in targeted high-risk groups. Instead of going in any community, we've mapped out high-risk groups, including people living with HIV, the contacts of people with active tuberculosis, and the hotspots that we have been able to generate the country. Then also the mobile clinics, plus the data-driven hotspot mapping leads to the efficient deployment. What we have done, again, relying on the Delft and the AI, we've been able to map out the hotspots in all the districts. We have 145 districts in the country, but we have mapped out the villages using this artificial intelligence, which is Epicon, to tell us exactly where TB is likely to be transmitting highly in the communities, and we focus our screening in those areas. The community engagement, of course, is very critical for the success of this. We have been able to engage communities, creating the awareness, and also trying to tell people, to create awareness about the system, but also to reduce the fear of radiation with the systems within the communities. So these are some of the things that we do while engaging in the communities, because the question is of the radiation in communities, and so we need to create that awareness and allay the anxiety. Next, please. Yeah, so the impact on program and people, we have improved the equity now. We have better reach for men, better reach for rural populations, and the asymptomatic people. So reach for men, when we are now doing our targeted outreaches, we know where men go for some of their leisure activities. So we try to target them there. And most of the times they don't have the time to come to the clinics. So we go to them, and this has been a better way to address the equity issues and also to the rural populations. So this has contributed to reduction in incidence and mortality. So we have data which we are modeling using our community screening and treatment, which has shown that by use of these interventions, we are able to quickly reduce incidence and mortality. we are strengthening data connectivity. So the CAD4TB is integrated with the laboratory systems so that we can be able to connect the X-ray findings with the patient data and also the laboratory information. This is not so widely spread, but we see that we are going into that right direction once we can be able to link this data with the laboratory and the other clinical data for the patients. Then the capacity building, we have been able to train people to task shift, meaning that we are training people who are not radiologists or radiographers, but we are training the nurses and clinical clinicians to be able to use these systems because they're easy to use. Otherwise, you will not be able to have enough human resource to use the qualified people. But the task shifting has really helped us a lot moving forward. Next. So what I'm saying that since this year we have developed a surge plan to increase the access, but also to optimize what we are doing so that we get better yields. So in our surge plan, we have identified 4 key populations that we want to focus on. For systematic screening, we are looking at people living with HIV, which is integrated in the clinical care clinics. We have also targeted screening at urban and peri-urban hotspots. As I told you, we have mapped hotspots using the EpiCode software. Oh, please go back. Yeah, and then the other area we are focusing on is the prisoners and also the refugees. And we think by reaching those 4 priority populations, we should be able to reach around 400,000 screened per year. But these are only the priority populations. The screening in clinics and facilities will continue and in some other populations. But these are just the 4 priority areas that I want to point out to you. Next. Yeah, we've had some challenges, and also we have the country level recommendations. On the left, you can see these are the challenges on the right-hand side of this slide. We have the proposed recommendations. We have the delays in laboratory tests for samples from X-ray screening that are referred to for gene expert testing. Because when we screen the community, sometimes if we don't have a van that has got the laboratory, if you just go with the X-ray system and the CAD4TB, you get the sample, but you have to take it to the facility. But now what you want to do on the right-hand side is to be able to couple this dict X-ray and CAD4TB with a molecular recommended diagnostic test for the outreach activities. Already we have 33 of these equipped with lamp equipment, and these are tricycles that can go into the communities carrying the portable digital X-ray, but also they have the TB lamp equipment. So we only have 33, but we are looking at making sure that we get more of those. The inadequate trained personnel to operate the digital X-rays, I've already talked through this. We have trained clinicians to operate the X-ray systems, leading to the task shifting we are doing. Then the other qualified people, we are advocating for recruitment within our local governments. Inadequate resources to support the community outreaches. We are engaging districts to leverage on the primary health care funds, integrate with other opportunities like child health opportunities, immunization opportunities, so that we can rely on those resources to do the screening for tuberculosis as well. Next. Yeah, the future opportunities we see that we need to expand all districts. So we think we have to get more of these systems so that we can deploy more and improve the access to the communities. We need to integrate the full linkage of CAD4TB with laboratory and treatment systems for same-day diagnosis and the testing. We need to have the AI-guided hotspot mapping for targeted outreach and efficiency. We need to align to the GC8 funding cycle. We are seeing that now we are in the process making an application to Global Fund for the GC8, and we see some opportunities here of trying to include our delight systems and CAD4TB. Then the pediatric screening, we need to innovate into the pediatric gap that we are experiencing, and also into the mouth disease application, because when sometimes we screen for TB using the system, but we know sometimes it's not TB, so we need another addition that can tell us about other lung conditions other than tuberculosis. Then, of course, the sustainability, we need to have local maintenance capacity and domestic financing. Next. Yeah, these are the takeaways that I have, that Uganda has moved from pilot deployment to the national scale-up sustainable screening for TB using the Delight mobile clinics and the CAD4TB, which are proven to have a high impact innovation. Achievements are significant, but challenges remain, and you have opportunities ahead. So our call on action is collaborative learning from the global elimination for tuberculosis. Thank you so much. That is the presentation I prepared for this. Thank you.